Lovely. Hello, my name's Sara Humphrey. So I'm going to talk to you about the approach we've taken in Bradford to support patients with frailty during the COVID-19 outbreak. I think the first thing that we need to do is really think about what's frailty, because that sets the context. So frailty is a person's mental and physical resilience, or their ability to bounce back after they've had an injury or an illness. And as you'll see from these slides, that a seemingly quite insignificant problem like a urinary tract infection in a frail person could end up with delirium, a fall, or problems with independence. Probably we've all seen this slide. This is the measuring frailty through the Rockwood Clinical Frailty Scale that accompanied the NICE guidance. And here you'll see on the left-hand side mild frailty being described. I've also put on this slide that people may want to have a closer look at in the future is some top tips that have been developed by Kenneth Rockwood that came out on the 9th of April. And so just really a couple of points around using the clinical frailty scale. It is only for over 65s and you just need to be careful with, it can't be used with people with learning disabilities. And when you're scoring people with dementia, mild and moderate and severe dementia do correlate with levels of frailty. So I'll leave that for you to have a look at when you get the slide set. And the next question really is, why is frailty important during COVID-19? Well, you saw the Rockwood scale, and this was part of a NICE rapid clinical guidance on critical care. What the guidance suggested is that people with a scale of 5 or more, you need to take really careful consideration about really whether they're suitable for critical care and ICU and ventilation. Doesn't mean they shouldn't have it, but you need to consider really carefully. And so that's where frailty suddenly came to the fore. What I want to show you next is some of the evidence around why that decision was made. So on this slide, you'll see that with increasing frailty score on the left, going down the left-hand side, you have increasing inpatient mortality. So once you get to a frailty score of 9, 30% of people will have an inpatient mortality. So what you need to be thinking of is your response needs to be framed within that type of conversation. The next thing they used was the survival plot for patients living with frailty over a 3-year period. So what you'll see here that with increasing frailty reduces your survival rate significantly over that 3-year period. And that needs to be your context for frailty. So I've lost a slide there. The next slide shows you some of the evidence they use. They use various publications that really showed that an evidence of frailty score of over 5 increased ICU mortality and the 30% 30-day mortality as well. And finally, they also looked at people with age and different comorbidities and cardiovascular and respiratory comorbidities. And again, the older we get, with those two comorbidities, the worse the outcome is. So they used that to frame that ICU critical care guideline. And so I think a lot of us have then used it to consider how we best support people with frailty. The next thing that we've done in Bradford is use data and to see how well our system is responding, not only to the challenge of COVID, but to interventions. So we have a COVID-19 dashboard, which brings together information across the system, information from 999 and 111 calls, the number of cases and positive swabs, the number of people going through both Airedale and Bradford. The orange boxes at the bottom are our numbers of cases in care homes, deaths, and staff self-isolating. But we've also got our ICU beds, our inpatient beds, and staff absence. So we can see COVID-19 as a system, and that's helped us see what's happening within the care homes. We also have a dashboard about capacity of beds, so that's helped us know where we're at. and whether we're coping with the outbreak, and we've done that for both of our acute trusts. And then finally, we've also looked at data to monitor our interventions. So we've done, and you'll hear about later, an intervention around advanced care planning. So we've used just one marker around DNA CPR rates across our, and this was our old CCGs because we're 3 come to 1, to monitor whether our interventions are working and where we need to concentrate efforts or where we need to put extra things in place. The next thing we did in Bradford was frame our programme. Where does frailty sit? So this really busy slide just brings the whole of the COVID-19 offer for our CCG around staff, around mental health, around our community, our primary care and our acute care trusts. And the red box in the middle is the programme that I'm part of, Care at Home. So we framed it within the whole of the offer to see where it's sat. What we have within our Care of the at Home programme is on the right hand side, you'll see the main bits of the programme. So something called My Care 24, Medicare and Goldline, which are our digital offer, which I'll talk about in a moment. Our superrota again, our new pathways of care, and then how we respond as a community to those needs on the ground. So those are all the main things in the programme, but then we've got the usual things, our enablers to make that happen. So, and I'll go through a few of them, but how we've used data, how we're monitoring and looking at infection control within care homes, PPE, swabbing, monitoring, our medicines management, our comms. We have a team of over 8 now with different skills, so how we all complement each other. And then what's coming more to the fore recently is our governance and the EQIA. But we've also looked at what are we doing as business as usual for our district nurses and how do we change that, or how do we make sure that it's suitable. So one of the big projects that I thought I'd tell you about was our deprescribing project. What we thought here really was that and what triggered it was that we had a change by our local pharmacists moving from Dosset boxes to what we call original packaging, the old bottles and things. And how could we, and that meant that care homes were struggling with the increased time it took, but also pharmacies with the amount of medication they were dispensing. So what we did was we looked at where we could reduce medicine burden and medicines of no proven benefit. And that led us on to medicines that have a high anticholinergic burden, or where we know that they put people at risk of delirium or acute kidney injury. We also looked at medicines that required external people to come in and deliver them, like B12 injections, and also things that needed more monitoring like warfarin. And so we made a switch to what's called NOACs, oral anticoagulants. And we put this all into a package and we asked practices to sign up. And then we employed some CCG, employed some pharmacists who were very experienced. And we looked at the evidence and drew up a plan. And we're going to monitor any medicines we stop after 6 months to see if they should be reintroduced. And we will switch back if required. So that's trying to reduce medicines burden. Our next really big project was around enhancing the offer of care with in conjunction with Airedale Digital Care Hub. So the Airedale Digital Care Hub already existed and already covers multiple homes around the country and prisons, and also covers some people within their own home. We already in Bradford use something called Goldline, and Goldline is our offer for end-of-life care. It's a 24/7 phone line and patients have to be referred in, and that's already very successful, but we want to really encourage all of our primary care now to think about using that for anybody in the end of life. A referral is required for that, it's not automatic. The next thing we've looked at is something called eMedicare, and we've put this in all care homes now in Bradford. We did have it in some care homes, but we've opened that offer now to all care homes, and we're in the middle of rolling it out. So for those care home residents, no referral will be required. They will just be automatically enrolled, and that's a 24/7 access to the digital care hub. And finally, a new offer is called MyCare24. MyCare24 was available before we started this work for COPD and Parkinson's patients, but now it's available for people with frailty and escalating need in their own home, who are identified by multiple practitioners, and they do need to be referred in with a plan. Our digital care hub now is also supported by 24/7 palliative care consultant advice, which they always have been, but we've plugged that in to make sure it's available to eMedicare and MyCare24. We've also agreed with our acute, with our care trust, Bradford District Care Trust, mental health support for older people from 8 AM till 8 PM at night. And finally, something I'll tell you a bit more about later is something called our superrota of virtual support. So that's our new digital care hub offer. Just take you through a little bit more detail in some slides later on. What we then did was made sure that our GPs could access all these systems through System 1. And so they understood what the pathway looked like. And that's called, and this I'm showing you now is something called our frail patient with escalating need pathway on something called GPAssist. We have other pathways that this is what we show for the care home use for eMedicare, to show them what kind of pathways they might want to put in place. And finally, this shows you what would happen through those pathways if they access the gold line, and it reminds them who to refer. What's important with the pathway to MyCare24, so this is new, already existed for COPD and Parkinson's, but now available to frailties, that they have to be referred in with a plan. The plan can be relatively simple, such as they want a digital care hub nurse to ring on a daily basis to make sure for the next few days that the patient is responding to their treatment for either COVID-19 or for their urinary tract infection. But it might include more complex requests, such as putting in a home care support package, having blood tests to rule out dehydration, or a feeling that they maybe need to be referred for virtual ward, have a multidisciplinary team assessment for because they're having multiple falls. It can include referrals to district nurses for continence or wound checks, or indeed to the third sector for food packages or befriending. So some kind of plan has to be put in place, though the plan, once started, can be improved upon and added to by the digital care hub. What we've also done is worked with our acute care colleagues to look at pathways of care to sort of maximise resources and reduce unnecessary transitions of care. These pathways, and I've just put them all in one page, we haven't done them for everything. What we've done is looked at where we think during COVID-19 we might need to deviate from previous usual practice. So, for instance, suspected head injury on an anticoagulant. Often patients were picked up by ambulance crews and went to A&E. And actually we've put something new in place where we might do observations, and if there is no neurological deficit, a patient may stay in the care home. So we've done them for quite a few things like suspected fracture neck of femur, and it's all about reducing transitions of care where appropriate to A&E. Another pathway that's mainly been of interest to our primary care colleagues has been the virtual verification of an expected death. So the Digital Care Hub already did this, but this is a pathway we put in place for all our Bradford residents, where if they're in a care home and a qualified clinician is not present at the time of death, and it's an expected death and that's recorded in the notes, then that verification can be done by the nurse in the hub with the support of the staff in the care home. We can't use this pathway for anything that's unexpected or sudden, but we're hoping that will support our care home colleagues and our primary care colleagues to support patients who are living or unwell. And finally, we've developed frameworks to support care homes and primary care and advanced care planning. I must say this was a particularly difficult one, and one that took us quite a while really to consider. I think it would have helped if we'd had a national framework around how to really have those difficult conversations, but we felt after a while that we just needed to do it, and we needed to do it across our district, so that practices weren't sort of doing something differently and some person ending up in the papers and getting themselves unwanted publicity. So we took on writing a document that helped practices with quite difficult cold calling conversations and a sample letter. We wrote them searches to understand those people most at risk of in care homes and housebound. We wrote them some top tips on both advanced care planning and around the law of DNA, CPR and best practice. And we took a district-wide approach. And just really of interest for people around governance is one group of us developed this this guidance, and then what we did was we took it to another group and used our chair to see whether the message was right and whether we'd been right in our assumptions and we hadn't just got on a roller coaster without considering how it might land with populations who are feeling extremely anxious at the moment with COVID-19 and their carers. And so far so good. It only went out last week, but we're hoping that will support practices. We've also taken time to make sure our external partners are aware of our new pathways. So we've worked with YAS, and this is one of the YAS, this is the way they write up their pathways for everything. So they've got a common framework for all pathways, and we've worked with them to say, if they go to a home, before they convey, think about not only using the Digital Care Hub nurses, but also the superrota, which I'll talk about, to ensure that that's the right thing for that person. And then finally, something called the superrota. What we've done, and we were very heartened at the beginning of the outbreak by one of our consultants from Bradford saying, actually, I work for Bradford Hospitals, saying actually take 3 months and go and work with the care homes and Digital Care Hub. We then got 2 more consultants from our Care of the Elderly in Bradford. We've got A&E consultants. We've got palliative care consultants, and then we've got GPs who've self-identified as being with an interest in palliative care, care homes, older people, gypsies, urgent care. We've said they've got to deal with uncertainty because it is a very uncertain time. They've got to be good at dealing with difficult conversations. It isn't a ring for advice service, it is dedicated shifts from 8 AM till midnight, either remotely or from the Digital Care Hub. And they may need to have difficult conversations with both patients, families and care home staff. It is ideally meant to be for Bradford patients, but we've allowed our clinicians that flexibility that if they want to support a care home in Portsmouth, they can do. And I've had conversations like that because that felt to me the right thing to do as a system. We're all in this together and all supporting. And a lot of these have been around palliative care and difficult symptoms management. So that superrota is open 8 till midnight. and they've got advice. What we then did was said that if we're going to be having very difficult decisions about who goes into hospital, those need to be considered, personalised, documented and supported. And we've used some tools that Tizzy Teal, one of our consultants, found from Nottingham, a colleague there, and I've written on this slide thanks to Nottingham for those, because it started as the ball rolling and really helped develop what it should look like in Bradford. This is the paper version of the decision tool, so the usual sort of history examination, the context of where somebody's coming from, what are their comorbidities, what's their level of frailty, and how do they manage, whether they've already had advanced care plan decisions and discussions and DNRs in place, and then putting that all together to say, what do we do next? We've given them, and I'll show you another slide later, a silver level of support. So we've got numbers of somebody on the ground the virtual superrota can talk to. In ours, under 75, that's an A&E consultant, and over 75s or over 65 in a care home, that's our care of the elderly consultant colleagues at both our acute trusts. 24-hour-a-day consultant palliative care support and consultant psychiatrist support should we need them. And that's really to make that difficult decision together. We then put this into a simple console on System 1 and that can be accessed through Assist for GPs, but also on a very simple looking template that piece of paper came down to, and recording their decisions, because we really think that the governance of recording those decisions are very important. Several of our consultant colleagues are on Cerner rather than System 1, so we've given them a bit of a crash course and access to a crash course in System 1, and tried to make their life easy as possible by just having these two templates that they can record everything. Just so that you know, that just takes you through that detail of that silver level of support. And then both our acute trusts have got their in-house sort of gold level of support for very difficult decision making. And what we said, if in doubt about whether somebody should or shouldn't be admitted, admit them, and then some of that decision making around invasive support in critical care can be made at gold level. We've got a very robust governance structure, which started at the very beginning of COVID. And then we've put a governance structure around our VIS plan, so everybody knows where it leads into. And then we've now, like all people, we were off running at 100 miles an hour with COVID. And now we're taking a little bit of a breath to say, and we were quite good. We've been quite good all along. I work in research, and so does Tizzy Teal, and a lot of the teams work in the CCG is around quality and assurance. So we've been keeping, documenting our evidence, but we've increased, we're now documenting how we make decisions, our EQIA, and looking at a risks and issues log, and starting to now look really about how do we know that we're making progress and our programme is having impact? And this is because really we've done all this for COVID, but I'd love it if this continued. So Walter, one of my colleagues, has put all this on a page. There's sort of our successes. So we've had some great successes in very rapidly building up our relationships across community health and social care, which have been amazing. We've put in place very rapid clinical pathways on GP Assist, and we've very rapidly got that remote offer in place, and comms has been both timely and very personalised. We have had challenges, I won't deny, around the IT stuff. But it's amazing, and Rachel will probably tell you, things that couldn't happen before suddenly seem to have happened because actually we're breaking barriers all the time. PPE has been a very big bugbear. It's one of our enablers, and it will always be a challenge. And I think we've found it quite challenging that some of the press coming out nationally, but also locally, around people thinking they can't come into hospital. I do think the outcomes are that more patients are receiving care in the safest place for them. Our secondary resources, instead of being used in the hospital, are now helping to protect those services by moving into the community. And we're manageable, and we're just steady away in Bradford dealing with the demand, and I hope that will continue. I think we've obviously benefited from lockdown earlier than London, and we've got a much more strengthened community response now for demanding responding to complex cases. And we're going to reduce, we haven't measured it yet, but we will be reducing pharmacy waste, workload and inappropriate prescribing. Before we ran the searches, we thought, oh, well, there won't be much to stop. And the answer is there's loads. We have benefited from learning. We've called it action learning, or one of our GPs calls winging it. We've had to learn very rapidly and learn very quickly from when, and then put new learning in place. But that feels right. We've done it all virtually. We've all learned new things, like you all have Zoom, Teams, conference calling, how to share those. It's been quite difficult sometimes with the learning, that balance of change, to make sure that we're still evidence-based and still we've got the governance. And then we've all been used, and we're using all staff to help with that decision making. So we tried to find you just some feedback, really, and we got this really nice bit of feedback one day while we were doing a session, saying how well that Weaver Court, one of our care homes, had found the system, and where they previously had to call for a GP to prescribe, that had all been done. So they were really supportive, because I must say care home sector are really struggling, and we need to be supportive in health to those challenges. So just a couple of FAQs. Do we visit patients? No, we don't. It's all virtual. Do we provide hands-on care? No, we don't. Those existing teams do that. Can GPs still look after the patients? Yes, they can, though we encourage them to use telemed. We've obviously spent a lot on the resource, and we'd like to really see it used and protect it for the future. Is everything up and running yet? No, it takes time to roll everything out, but we're getting there. And finally, can you find out more? Yes, of course you can. And we've put some email addresses here. Should you want to have copies of any of the charts or anything we've used, we're quite happy to share any of the resources. So back over to Penny, and I hope you found that useful.
That's brilliant. Thanks, Sarah. That's fantastic. Incredible what you've managed to achieve in a really short period of time. There were a few people in the chat box saying what an excellent pathway and how quickly you've managed to pull it together. Somebody bemoaning, wishing that they were on system 1-2, because things seem to be simpler when you are. Okay, so just I think what we'll do next, if we could move on to the slide with the Q&A panel, already done. And if I could ask Helen, Rachel and Alan to make sure that they're all off mute, that would be really brilliant. And perhaps if we could ask Helen, if you wouldn't mind introducing yourself first, that would be brilliant.
Yeah, of course. Hello, my name's Helen Farmer. I'm the Associate Director of Keeping Well in Hospital within NHS Bradford District and Craven CCG, and I'm supporting Sarah on this pathway work, which we're calling Care at Home.
Thanks, Helen. And Rachel, yeah, lovely, over to you.
Hi, I'm Rachel Binks. I'm the Nurse Consultant for Digital and Acute Care at Airedale Hospital, and I'm the Clinical Lead for the Digital Care Hub. And we've been, as Sarah said, live for a number of years delivering telemedicine into care homes, and have developed now a system where we can also deliver into people's own homes.
Fantastic, thanks Rachel. And then Alan, looks like you might still be on mute. Over to Alan.
Just testing.
Yeah.
Hi everyone. I'm Al Sherd. I'm actually a nurse by trade, and got into digital transformation really with through the lenses of being a clinician, I guess, working in acute and community care, and believe that digital is the future for so many of these things. And I'm currently working with Airedale on their digital transformation programme.
Brilliant, thanks, Al. So I think we'll just work our way through the Q&A. Thanks everybody, we've got lots of questions in here. I think if we start with the ones that relate specifically to the service, there are a few about some broader issues. So this one from Ripple G is around how will people living with dementia and their carers with no digital skills and with additional language needs be supported? And there was also one about people with other needs, so communication needs, how this service would support them too. Don't know who wants to pick that up.
I mean, Rachel here, I was just going to, in terms of other languages, we have actually utilised digital translators before, so can actually access people that can translate, and they can dial into the consultation if that's what's necessary. In terms of people with hearing issues, obviously we can do text messages and that sort of thing so they can see. The message or the question about people that are blind, I'm not sure is the answer to that, other than being able to hear what we say. We obviously can't let them see all the things we're seeing, but that doesn't mean that we can't do assessments and do some really good virtual support for them and their carers.
Do you mind if I just chip in there? So I think as Rachel mentioned, there's in Medicare, the company that we work with, who prescribe the actual digital platform to work with the care homes, they also have a contract with the British Sign Language, so we can get direct access to people who can do BSL. Certainly, in some other organisations I've worked in, it's something we've talked about a lot in West Yorkshire, is whether we look at the buddy approach, i.e., so if somebody's got a planned appointment through video, actually volunteer organisations that will go to the patient's property, set them up on the iPad, wait in a different room while the consultation takes place, and then take the iPad away. I've certainly seen it in youth activities where local youth groups want to get involved in supporting people that need help with technology. So even if it's not there all the time, I've seen it in some organisations where it's used as a community spirit thing.
It is obviously a challenge while COVID-19 is going on, and I suppose it's just one of those things at the moment that it creates another challenge around supporting people with dementia who may have had no IT skills before.
Lovely. Okay. Thanks, everybody. There's a question about preferred frailty scale. I know you've mentioned the clinical frailty scale. Is there anything else that anyone wanted to say about that? Sarah, is there anything to add around that?
It has been something slightly different. So obviously, I don't know how many people know, but Bradford is the home of the EFI score, which is the Clinical Frailty Index, which is more of a population tool. And we got all our GPs in Bradford to use that with clinical acumen to decide whether somebody had mild, moderate or severe. So I don't think it matters what tool you use, and there are several out there, and we've got several on our templates, but that's the one that was used by NICE in the critical care guidance. So rather than muddy the waters, we just decided to use that so that we were all talking about the same thing. But I don't think it matters what scale you use, but the EFI by itself you can't use. It needs to be with clinical acumen as well, or a clinical score, because the EFI is a population tool.
Lovely, thank you. And then a couple of related ones. So what's being done to ensure people are going to hospital if they need to, and can people still see their own GP if they choose to? Okay,
so on the first one, people still going into hospital, yes. So what we've done in the clinical decision tools, you'll see that we are supporting people to consider the whole context of the person, so all their comorbidities, but also to make sure that they discuss that case with care of the elderly to see if they would benefit from coming in for say oxygen and IV antibiotics, and we've just had those very similar discussions with our colleagues on the ground that we all have, well, we in Bradford have capacity bed-wise at the moment, so we want to make sure that everybody has fair access to services. So I would say by being the super rota, having care of the elderly consultants and myself a GPwSI on it, that care of the elderly is close to our heart, so actually we want to make sure that they have the same access. So it's not about excluding people, it's about making sure it's a considered decision. And if it's not, if a person doesn't want to go in, that we can put care into somebody's own home. And I've now forgotten the second question, Penny, sorry.
It was about whether people could see their own GP if they choose to within hours.
Absolutely. Lots of our GPs in some of the areas look after a care home. But again, what I've said to GPs is we don't, and they're cognizant, lots of GPs are doing lots of remote working, but we really want them not to be visiting homes. We want to keep as few people going into homes as possible. But yes, we have some practices who very much in hours have wanted to carry on looking after their patients. And so if they let us know, that's fine. But most people have been sort of quite busy. We've got high levels of sickness in general practice. So actually it's been, I think most people have found it supportive knowing that we've been looking after them. But yes, of course they can.
Lovely. Okay. Thanks, Alan. Okay, so a lot of interest in the buddying scheme that Alan mentioned, and Alan's sharing the link to that, or some links. That's brilliant. So we've got a question about the type and range of clinicians involved in the virtual hub.
So maybe Rachel can talk about the people involved in the digital care hub itself, and then I can just mention around the super rota.
Absolutely. So the digital care hub has been going for about 13 years, actually. We started with prison telemedicine, doing outpatient consultations, and since about 2011 have been doing Gold Line and Medicare, which is the care home service. So we have band 3 call handlers who take the call and take the demographics and the details at the beginning of the video call, and then pass the call into a queue for the band 6s. So the band 6s and band 7 nurses and therapists. We've had paramedics in the past. We find that as we develop our staff with non-medical prescribing and advanced skills, they tend to go off and do advanced practitioner training or advanced practitioner posts. So we have sort of got band 6s and band 7 nurses and therapists there at the moment, but we have had a mixture, as I say, of many different practitioners. We also encourage anybody, any healthcare professional, to come into the hub and support us, and Sarah will talk about the super rota. But we certainly utilise the skills of mental health practitioners, palliative care consultants for the Gold Line service particularly, and therapists as well. We run things like stammering services with our speech and language therapists, so and do lots of outpatient consultations remotely already. So a real mix of a sort of multi-professional team. Also a lot of admin support staff and people who know so much more about System 1 and systems than I do, who are wonderful and invaluable. And obviously managers and team leaders as well that do a really brilliant job, as well as our business analyst, Dr Mark Hawker, who gives us the most wonderful BI so that we can actually explain what we're doing and whether it's had an impact or not.
So with the super rota, this started off being 2 care of the elderly consultants and myself. So I work for Bradford Hospitals in care of the elderly, so I'm what they call a GP with a specialist interest, a GPwSI. We then got some A&E consultant support. So basically lots of people who might need to be isolating or shielding. You know, it's allowed them to work on to still work. We have a rehab consultant from Airedale, Dr Liz Stoppard, and we've got GPs with a specialist interest. We've got urgent care and MSK, people who work in care homes already, GPs who work on end of life, and often or otherwise very senior GPs. We were very clear that we wanted people who had who dealt with complex decision making. We've got the end of life 24-hour a day contact with palliative care consultants. mental health liaison nursing supporting the 8 till 8, who have direct contact with care of the elderly consultant psychiatrists. And then finally, we've just looked at today that some of our therapy staff are interested in actually thinking how can, because they're obviously not being able to get in and do their normal therapy, could they use the digital care hub as a way of delivering therapy? So we said, actually, yeah, let's start looking at that. And actually, that would really complement the team, especially around the My Care 24 and Medicare, because soon we're going to notice that, you know, therapy is not going to be going in is going to be important. So really, as Rachel said, a really wide range. And we've also got some pharmacy support, which is new. And suddenly we can prescribe, because we've now got turned on something called ETP, which has been amazing, because they couldn't prescribe before the digital care hub, even when they had prescribers. So suddenly lots of blockers have been unblocked. So it's been amazing, the quality of and access of that team now to lots of professionals.
Just to add to that as well, actually, Penny and Sarah, is that the nurses that we have working in the hub and therapists, their backgrounds are varied, really, from palliative care to emergency department to critical care to community and acute work. So they're a real sort of vast array, a vast range of experiences and expertise from the nursing team that take the remote calls and do the consultations. Lovely. Okay.
So we've got a couple about how this has been received. So, well, a request for, could we share by email some of the GP guidance that you've produced? If that's okay, we can just ping that out when we send the slides out.
Yeah.
Is that all right, Sarah? Yeah, okay. And then question from Jane Newbold about, did GP services come on board straight away, and has it reduced patients requiring GP consultations?
So, so I'm involved in 2 PCNs. I'm part of a super partnership that's in one and then actually part of another one. So we were very careful that we went to our PCNs and LMC and got them on board. I've then gone to several of the PCNs as well to talk to clinicians who are probably not in leadership roles. I think the biggest concern from one of them that I am actually part of, WACA, was around that. Are we going to lose that continuity of care of our own patients? But actually, what we did was say, some of them have actually come and worked on the super rota. So actually seeing ourselves as working together. So it's not one or the other, but we're all part of the same system approach to supporting care homes and recognising, yes, some people will still want to go in and see their patients, and it's not an either or, but we complement each other, and actually having access to the super rota has been really positive. So yeah, it's been so far really well received. Has it reduced GP contacts? Well, we're rolling out, so we're rolling out now. Quite a lot of the care homes are rolling out in the next 10 days. So the ones where we're measuring that, and that goes through our contracting. I don't have the figures here because we haven't rolled it out to all the homes, but that will be, we want this to continue. So we're going to be supporting Digital Care Hub to make the business case for My Care 24 going forward. And obviously, both Helen and I want to get the best value for money for the commission service around Medicare, so we will be monitoring that. Anything else to say, Helen, on that? Because you're really the contracting person.
No, I think, yes, Sarah's right. The rollout, we commenced with a kind of a soft rollout over the Easter weekend to support our nursing and residential homes, and the kit's going into the homes this week. So I think we'll really start to see an impact from this week. We do have previous experience with the Medicare telemedicine offer, where in particular in homes that have got a large number of beds, that's very well utilised and does prevent unnecessary calls to other healthcare services.
Yeah, just to add to that, Helen, I mean, we have some evidence from over in East Lancashire, particularly, where we reduced by about 40% the number of GP calls. And also we try and keep, obviously prior to COVID, but we try and keep around 90% of the people in their place of residence. That tends to be the result of our calls, and half of those will be referred on to GPs and district nurses and other teams that are supporting care homes. So there is some really quite good data, and we're really hoping to work on that and to improve that even more with the service going forward across Bradford districts and Craven.
Lovely, thank you. Just one quick one. So has there been any pushback from your local coroner on acceptance of remote verification of death?
So probably Rachel can talk a bit more about it, but no, he's been very good about that. We were hoping that we were going to have our funeral directors doing it all. We thought, what an ideal plan. He did put a bit of a spanner in the works about that, and we've decided to leave that battle. But what we've done is he's fine about this all being done, because actually the person doing the verification is not the care home staff, it is the nurse sitting on the digital care hub. And actually there's a paper, for anybody who wants to see it, come out from the BMA only yesterday about GPs doing it remotely. So our next plan is to develop a pathway for GPs to do it remotely for their own patients in their own home, not really part of this work stream. So we'll probably just lend them our pathway and let the LMC then take that on fully. But yeah, no, I think it's going to be out there. So I'm quite happy to send that BMA paper with this if anybody wants to see it. Or they can do it online if they want otherwise.
And Sarah, to add to that, we've literally just started a conversation today via the ambulance service around using our local police force to support us with some of that work, which might be another novel way of doing this verification of death process.
Yeah, that was a bit of a surprise when they came in suggesting that the police might want to do it, which was great.
Yeah.
It just demonstrates that whole system working, coming together, which I think has obviously been a key part as you've gone through this presentation, the speed in which everyone's in effect looking at other innovative ways that we can do things and supporting as a system.
Absolutely.
Lovely. Okay, so a couple of broader ones. So and they're kind of linked. So one is about the impact of 12 weeks of shielding on older people's cognitive and mobility abilities, and linked to that, carers. So how are different people dealing with respite? So any thoughts on that?
Well, I don't think we've got, so one of our members of the Care at Home board is Chris North, and he's not on the call today, but the Care Trust have developed a range of support materials for both people living in homes, but also care home staff and primary care staff. And I can see that now that we've set up the 8 till 8, that they may use that digital, that portal as a way of helping to support people with the mental health side of it. There is a debate going on around memory assessments and whether this can be done virtually. And as a network, we're going to host a webinar at some point soon. I don't think we've got a date yet, have we, Penny, around what are people doing about virtual memory assessments. So there's that, and around mobility and things. I think that's where maybe this thought about adding therapy support into the digital care offer may really reap benefits, because I can see that it is going to be a challenge if people are not getting out and shielding.
Yeah, and just to say, Sarah, as well, in the past we've actually done some virtual training with a number of care homes, including things like armchair exercises with therapists, you know, and sort of cardiac rehab classes and that sort of thing. Because once you've got this kit in place, once you've got the ability to deliver remote consultations and to dial into meeting rooms as we are now, then there's so much more you can do that you don't even realise, I think, until you've got the equipment and the technology there.
No, that's brilliant. Okay. Just while, I mean, there's one or two questions we haven't had time to pick up. Before we answer those, it'd be really helpful to get feedback from people who've been attending. We've had a little bit already, but about whether you found the session helpful or not, and if you'd like us to run something similar in the future, whether there are particular topics or themes that you'd like us to cover. That would be really helpful feedback. So just
Penny, could you mention our idea this morning around having a supportive webinar going on meeting once a week virtually to people to can talk about advanced care planning issues and get support from the clinical network advisors, and if they feel that they want to dial in, that we might have that up and running?
Yeah, so we'll hopefully, well, we've got a date in for next week, so we'll be sending around an email about that. We're calling it Conversations About COVID, keeping it very informal, and just chance for people to sort of come together remotely to talk about any issues they might be encountering, and have a chance to talk to the clinical network team. Yeah, thanks, Sarah. So just a couple of final quickies, hopefully. Now then, I've lost it now. You've covered prescriptions already.
There was one there, Penny, about mental health practitioners being able to refer into MyCare24. The answer to that is that yes, anybody can refer into MyCare24, but there has to be a plan in place. So we act as a coordination centre, and we can do proactive calling and that sort of thing for people in their own homes. But we have to have a plan in place, an idea of what it is that you want us to do for your resident, for your patient, your client.
Brilliant, thanks, Rachel. There was one, I think, about whether care homes were carrying out observations.
Oh yes, I forgot to mention this. There's so much to put in. We've also bought kit for all 140 care homes. We bought them 2 pulse oximeters, if they didn't have them, thermometers and blood pressure machines. Sorry, I forgot to mention this. And we are going to train them to use it so that they can take observations. Most people had thermometers and blood pressure machines. Not as many had pulse oximeters, but yes, we bought them that kit out of our budget at the CCG. And I forgot to mention that, and I will mention that to primary care because they will ask.
And part of the assessment, just to add to that, part of the assessment and the reason we wanted all this kit in place is because we always work out a national early warning score when we are doing an assessment, so that we can have baselines in place and we can actually see if somebody's beginning to deteriorate as well.